Okay friends, today we'll be discussing the first lecture in our series of knowing ECGs, and this ECG lecture will be just on basics. It will not change your perception from your books, but it will give you a very basic background of how ECG is being generated, the vectorial analysis, the electromagnetic analysis, and how the waveforms, isoelectric lines, P wave, QRS and T waves are formed. We'll just know that in detail. So you have to imagine a lot of things while I'll be discussing this ECG genesis. Just imagine this as a heart, right? This is your left ventricle muscle wall, this is your interventricular septum, this is your LV free wall. You're able to get it probably. You have SA node, which is situated on the junction of superior vena cava and right atrium. From SA node there is a connection towards your AV node, and from AV node you have left bundle and a right bundle branch. If I just cut a cross section of this muscle and just magnify it in its resting membrane potential, what I will see is that each cell is negatively charged from inside. So this is known as resting membrane potential. Now how do we record the ECG? In any lead, you have to have either a negative electrode and a positive electrode. So suppose I take any lead, say lead 1, and I have a negative electrode here and I have a positive electrode here. So what leads capture is the movement of charge. They don't capture the absolute charge. Whenever there will be a movement of charge in any direction, the leads will capture them. So if I have a negative lead here and a positive lead here, but no net movement of charge, you will always have an isoelectric line, a straight line. There will be no upward deflection, there will be no downward deflection. Now just imagine that I stimulate this cell from here. I stimulate it. So what will happen is, suddenly there will be flow of calcium and sodium from outside. So the cells will start becoming positive, 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 positive like this, and there will be net movement of positive charge from left to right. So there are some principles in electrophysiology that whenever the positive charge moves towards positive lead or positive electrode, the deflection is positive. So whenever a positive charge move towards a positive lead or the positive electrode, the deflection is always positive. So there will be a time when the whole cell is depolarized. The whole cell is depolarized. When the whole cell becomes depolarized, there is no net electrical movement. So again there will be an isoelectric line during the recording. But to get the cells stimulated again, it has to go back to its resting membrane potential, that is negative. So again there will be movement of this positive charge outside, so it will be negative, 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 negative. There will be movement of negative charge. Now again you have to remember this principle: whenever there is a net movement of negative charge towards negative electrode, the deflection is positive. Positive charge moving towards positive electrode, deflection in ECG is positive. Negative charge moving towards negative electrode, deflection is positive. Negative charge moving towards positive electrode, deflection is negative. Suppose I change my lead. So in this example I change my leads. I make this lead positive and here I make it negative. So when I stimulate it, this positive charge will start moving towards the negative electrode, so deflection will be negative. So this is the standard principle of electrophysiology, wherein the movement of charge decides the deflection in the ECG. Positive charge, positive electrode, positive deflection. Positive charge towards negative electrode, negative deflection. Negative charge towards negative electrode, positive deflection. Now when we talk of 12 lead ECG, we have 3 bipolar limb leads, that is 1, 2, 3. We have 3 augmented unipolar limb leads, AVR, AVL, AVF, and we have 6 precordial leads. A combination of these 12 leads constitute the 12 lead ECG. Herein you have to understand that bipolar and augmented unipolar limb leads are in the frontal plane. They are in the frontal plane, whereas the precordial 6 leads are in the transverse plane. Right? 6 leads in the frontal plane, 6 leads in the transverse plane. Now when we try to understand the very basic of ECG, we always take lead 2. There is a reason. In lead 2, you have to remember any electrode which is negative and which is positive, the I of this lead is at the positive electrode. By I it means from where this lead is looking. If I have negative electrode on my right shoulder and a positive electrode on my left shoulder, so this lead is looking from this side. I am not looking from my negative side. So every time whenever you imagine a lead, always imagine looking into the heart from the positive side of that lead, from the positive electrode side of that lead. So as a matter of convention, we have lead 1, in which negative electrode is at right shoulder, positive electrode is at left shoulder. This is known as lead 1. Lead 2, again negative electrode at right shoulder, positive electrode at left foot, left leg. Thirdly, lead 3, negative electrode at left shoulder and positive electrode at left leg. If you just imagine your heart suspended in your thorax, it is always looking towards your left leg. It is down and it is slightly left. So out of all these 3 leads, it's mostly aligned towards your lead 2. If you just imagine lead 2, if I pull this lead 2 and put it over this heart, it will be aligned exactly like this, right? So as a matter of convention, for understanding purpose, how the ECG is being depicted, lead 2 is being taken because it is the most aligned lead as the electrical axis of the heart. So what happens in lead 2? So I'll just draw an ECG depicting all waveforms in lead 2, and then what we'll do is we'll try forming that ECG in all other leads, right? So you have to just imagine now that this SA node starts firing. As soon as it starts firing, you have small vectors which are being generated, small vectors. Now what are vectors basically? Vectors is nothing, they are force with a direction. Force with a direction in 3-dimensional space is known as a vector. If the force is more, the vector is strong. It can be depicted as a long vector or a thick vector. So there are cells which will form individual vectors, right? So this is a wave of depolarization which is being spread. When I take the mean of all the vectors of atria, what I will see, the mean atrial vector is formed towards AV node like this. There are small vectors of thousands of cells. When I summate those cells, what I found is that majority of the electrical energy is being directed towards the AV node. So you have to imagine that this lead is here. So minus and plus. The I is looking from behind. This is my I. So what is this vector? This is a movement of positive charge, as we showed earlier. Whenever there is a stimulation, the positive charge starts moving. So there is a net movement of positive charge from SA node towards AV node. So what this I will see that some positive charge is coming towards my positive electrode. As soon as this I will see that some positive charge is moving towards the positive electrode, it will give me a positive deflection known as P wave. Have you got it? There is a net movement of positive charge across all the cells in the atria. The cells are being depolarized. The net vector is directed towards the AV node, and during this depolarization, this net vector will be picked by the positive electrode of lead 2, thereby giving rise a positive deflection. Simple, right? Now one very important thing which we need to understand is, if I cut the atria, if I cut the atrial wall will look like this, which is a thin wall. And the transmission of impulse in the atria is longitudinal, means it is like this. It goes like this in circles. It is not from cell to cell, it is not in parallel, it is in series. And that is the reason the atrial cells are more prone to develop atrial fibrillation if we compare them to the ventricular cells. Because in ventricles, if this is a ventricle cell, the spread of impulse is like this, from endocardial surface to epicardial surface. So electrical current in ventricles, it goes from endocardial surface to epicardial surface. It is in series like this. Herein the flow of current is from cell to cell, but it is longitudinal. So suppose, just imagine the atrias are stretched beyond a limit. So as the depolarization waves reaches distally, the proximal cells will be out of their refractory period. So it can have a automaticity. So you can have atrial fibrillation. Whereas in ventricles, even though they enlarge, the activation will be simultaneous. Even though the ventricles enlarge to their double size, the activation will be simultaneous. So that is the reason VFib is very less common as compared to AFib. One more important aspect is, even if the atria hypertrophies, we always say atria enlarges. Reason being, atria can hypertrophy, but we cannot judge it in ECG, because the movement is like this. When the movement is longitudinal, you cannot judge the thickness, because it has to be vector, and the power of vector which will tell you the magnitude of deflection. Okay, so the direction remains longitudinal. So even though the atrial valve becomes thicker, the direction remains same. The intensity of the vector remains same. So we always say enlargement. We never say hypertrophy, because we cannot judge hypertrophy. Wherein in this, because the vector intensity will be more as compared to this vector, we can judge the thickness of ventricle by looking at the ECG. I hope this is clear. So we have a net vector which moves from SA node to AV node, and this net vector is being picked by my lead 2 positive I as P wave, right? Now you have always seen after P wave there is a small isoelectric line. After a P wave, we always have a small isoelectric line which we call as PR segment, right? Now why there is an isoelectric line? There is a movement of charge. There shouldn't be. What happens is, this charge, it touches AV node, and AV nodes depolarizes. The moment AV nodes depolarize, it acts as a guard. Say for 0.1 second, it will hold the charge. So there is no net movement of charge. If there is no net movement of charge, what you will get? Isoelectric line. So there is no net movement. So you get an isoelectric line known as PR segment. In our subsequent lectures, we will understand the significance of PR segment, but just to give a basic concept, PR segment is very important to judge ischemia and infarction of atria, because till PR, you don't have a ventricle which is there. The electrical activity is still till AV node. So whatever happens at PR, maybe it goes up or it goes down, it will tell you some pathology, some ischemia or some infarction of atria, right? In which leads will come in the subsequent lectures. So you have a PR segment which is formed by AV node holding the charge, say for about 0.1 second. Now what is PR interval? PR interval is when you add P wave into the PR segment. This is PR interval. So there is a fundamental difference in PR segment, P wave and PR interval. PR interval is P wave plus PR segment. Got the point? Now pay attention that now the electrical signal will pass in the septum. The electrical signal will pass in the septum. So there will be septal depolarization. Here we have a atrial depolarization. Now we have a septal depolarization. So we have left bundle branch and we have a small right bundle branch. It's a fact that septal depolarization is being done by left bundle branch. So this branch will start depolarizing. So what will happen? Positive charge will move from left towards right, like this. I hope you are getting the point. If this is my septum and this is the left bundle branch, the moment it starts depolarization, the positive flow of ions will be like this towards left. So wave of depolarization, it starts from left border and goes towards right. So what will be the direction of vector? The vector's direction will be somewhere like this, slightly up and slightly right. And now just imagine this positive eye is looking towards a vector which is going up and towards right. So positive charge going up and right from this eye. So the deflection will be negative. So there will be a small Q wave. Okay, a small Q wave. So Q wave is not pathological. This is a physiological Q wave. A small Q wave is a physiological Q wave, which means the septum has depolarized. In better terms, it is known as septal Q wave. It can be pathological in certain leads where it shouldn't be, or it's very wide or it's very deep, then it becomes pathological. Otherwise, a small Q wave is a depiction of the vector of septal depolarization, which is slightly going up away from my positive eye of lead 2, right? Once the septum is fully depolarized, the waves of depolarization will start moving down throh Purkinje fibers, bundle of His, and it will reach the LV and RV. In LV and RV, they are negative from inside. They will start turning positive fast from this surface towards this, like this. The movement of charge will be like this. What will happen? There will be, see, LV is thick, very, very, very thick. So there will be a resultant vector from RV which is like this, but there will be a thick vector, something like this from LV. So this eye is seeing two vectors. One is going in left and down, one is going towards it. So it will pick this vector, or it will summate this vector. Suppose this is 1, this is 8, the summation could be 7, but still it is plus 7. So summation of these two vectors will give rise to a big wave known as R wave. So this is known as ventricular depolarization. But mind you, the ventricular depolarization is not complete yet. It is the anterior wall only. It is the interior wall which is being depolarized. See, the electrical charges are moving from bundles, Purkinje fibers, and spreading downwards and stimulating the heart from inside towards outside. So wave is spreading. Now what will happen? This wave will start moving backward. It will start moving backward towards your posterior surface of the heart and going towards the base. So if heart is a tubular structure like this, the current flows like this, goes to the apex, and then it goes down below and towards the base. So it's the same movement of positive charge, but what will happen? This positive charge is moving now in a direction which is backward. So what will happen in lead 2? Positive charge moving away from positive, it will give a negative reflection. So it will be S wave. This is S. So S wave is nothing, it's a diffraction of positive charge, and it depicts that your base of heart and your posterior surface of heart is being stimulated. Then this S waves meets isoelectric line, which is known as J point. So whenever we say J point means the meeting point of S wave with isoelectric line. Why there is isoelectric line now? Because the whole of ventricle is depolarized. Now it will contract. There is no net movement of any ions, it will contract now. So this contraction is taking place here after J point, right? And then it will start repolarizing, because it has to be depolarized in next cardiac cycle. So it will start repolarizing. In repolarization, again, as we have seen, there is a movement of negative charge towards negative electrode. See, the negative charge is outside, positive charge is inside. What will happen? The charges flip. They will flip like this, from outside to inside, from outside towards positive, towards inside, towards negative. So what will happen? There will be a positive deflection known as T wave. Okay, so I'll summarize this again. PQRST. P wave means atrial depolarization. You have small vectors which are distributed widely over the atria, but when you add them mathematically, the resultant vector is down towards AV node, which is picked by this I of lead 2 and is given a positive deflection known as P wave. Then you have a PR segment. PR segment is nothing that the charge has depolarized the AV node, but AV node is holding the charge. It is not letting the charge go down the bundle branches. So it is giving rise to isoelectric PR segment. Then you have a Q wave, because this septum is being depolarized not by right bundle but by left bundle. So the movement of charge, net charge, will be from left towards right and slightly up. So whenever the movement of charge, positive charge, is from left to right and slightly up, this I will see the positive charge going away from him. So it will give rise to Q wave. Then you have a rush of charge through the bundles, Purkinje fibers, and from epicardial to endocardial surface, giving rise to a robust R wave picked by this I. And then these charges move towards the posterior surface of the heart and will go towards the base. So positive charge going away from the positive eye of the electrode, it will give rise to S wave. This S wave will meet the J point. J point is nothing, a meeting point of this isoelectric line with S wave. Now this is fully depolarized ventricle, and when it starts repolarization, the negative charge starts flipping. It flips. The moment it flips, see, suppose this is my negative charge, this is my positive charge, it flips like this. So negative charge is moving away, or it is moving towards the negative electrode. So it will give you a T wave. I hope this is clear. See, this is lead 2. Now you have to imagine the same thing happening in lead 1. It's the same thing happening in lead 3. You just have to imagine. See, if I take lead 1, the eye is looking here. If I pull this lead 1 and put over the heart like this, so something is negative here and something is positive here. So my eye is looking here. Can you see that this eye is looking towards the left side of the heart, high upper left side of the heart? So we can judge that lead 1 will tell you the pathology happening high lateral valve of LV. You know, this eye is right here. So whenever there is a pathology in lead 1, so it will be telling you the exact area, which is left free high lateral wall of LV, right? Now imagine this vector which is going down and towards left. So it is net movement of electrode, the net movement of vector is towards positive eye. So there will be a positive reflection, but the magnitude will be less, because it is not directly going to the positive electrode. It is somewhat going to the positive electrode. So there will be a P wave, but P wave amplitude will be slightly lesser as compared to lead 2. You're getting the point? Because the net movement is towards positive, but the total movement is not towards positive. Suppose I rotate the heart leftward like this. So then what will happen? The resultant vector towards AV will be totally focused towards my positive eye. So suppose there is left sided movement of heart like this. So my lead 1 P wave will be taller. I hope this point is clear. The moment I have emphysema and my heart is tubular going down, my P wave probably will be more lesser in amplitude in lead 1, because the vector is pointing towards down. Just imagine, it's a hypothesis. Just imagine this vector is exactly looking perpendicular to lead 1. It can happen. It can happen. It's a hypothetical question that this vector is looking perpendicular to the axis. So what will happen? Anything which moves perpendicular like this, so something going towards the axis will give positive deflection, something moving away from the axis will give negative deflection. Positive and negative will cancel, there will be no net movement. So ECG machines are smart. So if the movement of charge is perpendicular to the axis of your lead, so the moment it goes towards the axis, the charge is positive. The moment it goes down, it is negative. So it cancels out. So you may not find a P wave. So right. So deflections depend upon the intensity in millivolts plus the direction towards the lead. Getting the point? Now you just see, you have PR segment, which should be common because AV node is not letting any charge out. Now you have a septal wave which is up and towards negative. So it is going towards negative. So you have again the Q wave. Simple phenomenon. A charge moving away from positive. So you just have to extrapolate it. If you extrapolate lead 1, lead 3, you will find a similar morphology of PQRST. You can just find that the intensity of fluctuation can vary. So lead 1, lead 2, lead 3, PQRST will be exactly same, but their amplitude may vary. The robustest, bestest amplitude will be in lead 2 because it is in the alignment of electrical axis of heart. Lead 1 and lead 3, because they are not aligned exactly in the electrical axis of heart, will show similar deflections, but the amount of intensity will vary. Right? So this is known as bipolar limb leads, wherein you have two electrodes, positive and negative. Then you have unipolar augmented limb leads, which are known as AVR, AVL and AVF. Now what is AVR exactly? AVR means you have a positive electrode on your right arm and you have a mean of negative electrode which is here. So this is your AVR. Augmented unipolar AVR means positive electrode on right arm or right shoulder, but negative electrode at mean of left arm and left leg here. So this is the axis of AVR. Positive here, negative here. What is AVL? AVL is you have a positive at your left shoulder and an average of right shoulder and left leg, negative, negative. So it is like this, somewhere like this. So this is your AVL. Similarly, you have AVF, where the positive electrode is in your left foot. You have a mean here, and this is your AVF. If you just imagine, I pull lead AVF and place it like this here. If I pull this AVF lead and place it over my heart, it will technically look like lead 2. Lead 2 was like this, AVF is like this. So technically it will look like lead 2. If I pull AVL like this, place it here, it will somewhat look like lead 3. The only changes in the direction slightly. The only problem is with AVR. The positive electrode is at shoulder. So the moment you put positive here and negative here, everything reverses. Everything reverses. It is exact replica of your lead 2. So your P wave is negative. You have isoelectric segment like this, and your T wave is also negative. So it is exact replica of your lead 2. Lead 2 was this, lead AVR is opposite of this. Right? I hope this is clear. So if we concentrate on bipolar and augmented unipolar leads, which part of heart they are really examining? If I say one is examining this part, left high lateral. So lead 1 is examining left ventricular free wall, but it is high lateral, because the positive electrode eye is at my left shoulder. Lead 2 and 3 positive eye are at my left foot, so they are looking at the inferior part or the apex, inferior part or apex. If we see AVR, AVR is here, it is looking from this part. So where it is exactly looking? It is looking high septum, this part. So remember, if you have a high septal infarction, you have changes in AVR. Plus, this area indirectly look towards your right ventricle also. So when we talk of problems in AVR, we are technically dealing somewhere in high basal septum and right ventricle. If I talk of AVL, AVL positive lead is again here on my left shoulder. AVL positive lead is again in my left shoulder. So where it is looking? It is looking at LV free wall. So AVL and lead 1 are looking on my LV free wall high lateral. If I talk of AVF, again its positive electrode is in down, so it is with 2,3 AVF, inferior part or apex. So grossly in frontal plane, we are able to see LV free wall depicted by 1 AVL. We are able to see inferior part or apex of heart by 2,3 AVF and right high basal septum and RV by AVR. Alright. Now we will come to precordial leads. I hope generation of PQRST is absolutely clear what they mean, right? QRS doesn't mean contraction. QRS just means depolarization. So now we come to precordial leads. So first we need to learn about the placement of V1 to V6 leads. So what you do is that you find your sternal angle, go down 2 ribs, just write 4th intercostal space, just at the side of your sternum you put your lead V1, right? Left 4th ICS, just adjacent to your sternum is your lead V1. Left ICS 4th space is your lead V2. Right ICS 4th space is V1, left ICS 4th space is V2. We forget V3 now. Now you go to 5th ICS, mid clavicular line, you put your lead V4. And in this diagonal V2 to V4, midway you put your V3. For V5, again you move in your left 5th ICS, go to your anterior axillary line, and for lead 6 you go to your mid axillary line, right? So V1 is right 4th ICS, just adjacent to your sternum. Lead 2 V2 is left ICS 4th, adjacent to your sternum. You omit V3, directly go to V4. V4 is mid clavicular line 5th ICS, mid axillary line 5th ICS lead 5. Sorry, anterior axillary line, and mid axillary line is your V6. And in this diagonal line between V2 and V4 you put your V3. These are unipolar leads, means you are putting your positive eye on your chest. You are not putting any other thing. What is happening is your ECG again is very smart. It is picking your negative electrode, it is making the negative electrode on your right foot. Okay, so you put your V1 to V6 accordingly, and they are known as unipolar leads. So this is your sternum, this is your heart. So V1 is here, V2 is here, V3 is here, V4, V5, V6. So the same principle applies, exactly the same principle applies on generation of P wave, QRS and T. But the way of looking from the camera is different, right? So we are not interested in P and T as of now. We are talking of genesis of ECG. So we are more interested in QRS complexes in V1 to V6. So the most important thing to remember is R by S ratio, or what you call as R wave progression. Why this is important is because if we don't know this, then change of the axis of heart and ventricular hypertrophy, when we will be talking about, it will be difficult to understand. So it has to be very clear, what do you mean by R by S ratio and what do you mean by R wave progression. So what happens is, imagine that AV node has conducted the positive impulses downwards. LV vector is strong, robust like this. RV vector is small like this, thin vector like this. This is my eye at V1. What do you think? What should happen? How the QRS should form? This is a small vector, very small vector. So probably my RV will be small, like this. Something coming towards V1 will be small because it's a small vector. But there is something going away from this which is big. So it will be like this. So R by S ratio will be less than 1. R by S ratio will be less than 1. There is a small R wave and a deep S wave in lead V1. Now just follow this. In V2, you will again have a R which is slightly bigger because it is nearer, right? And this vector is being picked and it will be slightly less deeper, but still R by S will be less than 1. Similarly, as you move towards V6, what will happen is your R by S ratio will starts getting equalized and it will become more than 1. So there will be a point where you in V6 you will have only something like this. In this it will be something like this. In this it will be something like this. I hope you are getting the point. Here V6 is not capturing the RV vector. It is purely capturing this robust positive vector, and that is the reason it is giving rise to a big R wave. So there is R by S ratio which is now more than 1. Is it very clear now? Right? Why R wave is small in V1 and why R wave is big in V6? It is because of the alignment of LV and RV vectors. Now, just before ending this lecture, I'll just tell you in brief about normal PQRST values, and the significance of those will come to different lectures. See, if we talk about P wave, I hope before getting into this we should know about ECG paper. If you don't know, you know about ECG papers? You don't know. Okay. See, ECG paper is, you have a square like this, large square which is 5 millimeter long and 5 millimeter height. There are 25 small squares like this. So each square is 1 by 1 mm. This 5 millimeter is equal to 0.20 seconds. So one small square is equal to 0.04 seconds. So this is the time on x-axis. On y-axis you have displacement. So 5 millimeter on this y-axis denotes 0.5 millivolts of current. Okay. Every small square upward is also 1 millimeter. So whenever we talk of deviation, say for example we talk of ST segment elevation, we are talking on this y-axis. So this small squares we have to count. 2 small squares means 2 millimeter of ST elevation. 2 small square downwards mean 2 millimeter ST depression, right? So when we talk of P wave, normally P wave height is less than 2.5 millimeter, usually 2 millimeter. It cannot be more than 2.5. It is, if it is more than 2.5 millimeter, there is a pathology. We are not going into that. Similarly, the width of P wave is 0.11 seconds. So you can arbitrarily say 3 small squares, say chota, 3 small squares, because 3 into 0.04 will be 0.12, so it is 0.11 second. So P wave should not be more than say 2.5 small squares. So a normal P wave morphology is smooth, upstroke is smooth, downstroke is smooth, the width is 0.11 second, the height is never more than 0.25, ideally it is around 2, right? Now you have your PR segment. This is your PR segment. We already discussed in brief that PR segment importance is in atrial infarction and atrial ischemia, because till this point the current has not passed into ventricles, so we can't tell about ventricles. So PR interval is from start of P wave to start of R wave. This is known as PR interval. So normal PR interval is always less than 0.20 seconds. Always less than 0.2 seconds. Means it can never be more than 5 small squares. The moment it becomes more than 5 small squares, we are probably dealing with some blocks. What blocks? Will come to the next lecture. Then you have QRS complex. Again, QRS complex, you must have heard narrow QRS and broad QRS. Broad QRS. Normal QRS is narrow QRS. So narrow QRS is not pathological. Narrow QRS is normal QRS. The problem is in broad QRS. So what is broad QRS? Any QRS which is more than, say, 0.11 seconds. But 0.11 is difficult. So remember 3 small squares. So again, P wave more than 3 small square, QRS more than 3 small squares is pathological. So if you have a QRS which is more than 3 small squares, 0.12 seconds, it is pathological. It is a wide QRS complex, right? Then you have ST segment and QT wave. This is your QT, Q till the end of T. This is QT. If we talk about QT interval vary with age and it varies with the heart rate. So if we say that the heart rate is, say, 60, so in male or female, if we talk about male and female, it varies somewhere around 450 milliseconds. 413 males, 415 females. But for the sake of convention, you can take at 500 milliseconds. So any QTC or QT interval, if it is more than 500 milliseconds, it is pathological. But QT varies with heart rate. So that we'll discuss later on, the formula for QTC correction. But in male and female, it is in males it is 430, female 450, and you have 500 milliseconds, which you can take arbitrary as a normal QTC. All right. So okay, friends, we have probably finished our vectorial analysis. We'll just in 2 minutes we'll briefly summarize what we have learned. We understood that there are 6 leads which are in the frontal plane, right? We have 6 leads which are in the transverse plane. Each lead has a positive electrode. That positive electrode is the eye of that electrode. That means that that's the camera from which you are looking towards the heart. There is only one lead which is looking from the top, which is AVR. So it is looking in the cavity, in the base of the heart. So AVR is looking towards your septum, which is high septum, and towards your RV. Lead 1 and AVL, they are looking towards your left ventricular high free wall. Lead 2, 3 AVF are looking towards your inferior wall. If we talk about bipolar and augmented unipolar limb leads, apart from AVR, all leads look same. They should look same. So just for for the sake of concept, you have to understand this. Whenever you encounter an ECG where lead 3 or lead 1 or lead AVL or lead AVF morphology is not similar to lead 2, or they have dissimilar morphology, that means there is some problem. Lead AVR is exact mirror image of lead 2. So 1 AVL, 2, 3 AVF, will look exactly similar. When we talk of precordial leads V1 to V6, we should thoroughly remember their placement. They are unipolar. These are their positive electrode. The negative electrode is at right foot. You should know the R by S progression. R wave is small in V1 and it grows larger to its maximum amplitude in V6. Similarly, S wave is deepest in V1 and it slowly grows into minuscule state at V6. I think we stop the lecture now and we'll see you again next time.